Good afternoon, everyone. Thanks for joining us for the December Crucial Conversations, which is part of the Charlotte Maternal and Child Health Workgroup. We are excited to welcome a different perspective to our space. We tend to do a lot focused on what's happening in our community around maternal and child health or research that's happening around maternal and child health in this moment. But I am so excited to shift gears a little bit. And today we are welcoming Dr. Bethany Johnson, who has a doctorate in the history of science, technology, and the environment from the University of South Carolina. She just received that degree this year. So we are super excited, for you to welcome you into this space. Her research explores how institutions and individuals create, normalize, and reproduce science, medical technology, and public health discourse from the 19th century to the present. So specifically, she studies the history of epidemics, endocrinology, and reproductive health. She is published in various journals. And as somebody mentioned in our intros this morning, she is also a co-author with Dr. Margaret Quinlan. You're Doing It Wrong, and I'll put this link in the chat. You're Doing It Wrong, Mothering, Media, and Medical Expertise. And we are just very excited to turn things over to Dr. Johnson to lead us through her presentation today. Thank you for being here.
Hey, everybody. Thank you for coming. I am really excited that we have some epidemiologists and a family practitioner and students in the group. What I'm going to try to do is do about a 40-minute presentation, and then I'd really like us to talk because there are folks in here that are far more familiar with current policy stuff than I am. And I'm hearing that people have a lot of personal experience with the topic, whether being a parent or being a caregiver. So what I'm going to do is I'm going to share my screen so that you can see my presentation. So the ways I want us to be thinking about is that I did change the order from my title. In my title, it says economically, medically, politically, but I'm actually going to start with the medical fallout because whether or not people had trouble recovering, they did take medical issues with them that were then made more complex by economic difficulties and the political struggle to get what they needed in the aftermath. So I wanted to start where it really begins, which is with the medical piece. Something that all of us, I think, probably know and have learned is that women and children face unique challenges in many different realms of public health. And the aftermath of pandemics is another one of them. Why that is something that we'll talk about today. Obviously, it has many, many answers. But in the 1918 influenza pandemic, it had to do with who died. And it was most likely that men between the ages of 20 and 40 would die. And I have some theories about that if we want to talk about why that might be later. But this meant that there were lots of widows and lots of orphans, and we'll talk about how that was defined. And that set people up for economic and political difficulties and left no margin for a long recovery. And what it ended up doing, unfortunately, in Philadelphia is leading to the dissolution of thousands and thousands of families. And we have different tools now that we can think about how to prevent things like that happening. And we can look at kind of what has been happening in the aftermath of COVID. And we can think about how people are being affected and what we can continue to do in response. Another thing we're going to talk about is policy. There are very familiar policy recommendations, widen and deepen social safety nets. Not a surprise to anyone here, expand preventative health programs. I'll be able to talk particularly about why that's helpful in the aftermath of viral pandemics today. Some of the less familiar things that, well, maybe not less familiar, you all will correct me. The focus on local or hyper-local responses, this is something that we can be doing in our communities. I know, Dr. Oni, you were talking about how this might impact how communication is like together. And hopefully I'll have some stories that will be able to touch on that today. And then I also want us to be thinking about the social model of disability. what do I mean when I say that and thinking about how to put it in sort of layman's terms? The medical model of disability says, hey, if you are chronically ill, if you have a mobility issue, we want to try to fix that or help it get better. And we want to kind of medically address it. And certainly a lot of people need and want that support. The social model of disability says, you know what, sometimes that's not possible. Sometimes a fix or a healing isn't the goal or isn't where we're headed. And so what we can do is change our environment and change social acceptance of disability to offer another way for people to exist and live well. And that's a question we really have to think about in the aftermath of pandemics, including viral respiratory pandemics, because they can change people's health radically and for the long term. And that's something that we're going to discuss as well today. So we are going to start, of course, with the medical side. What was the medical fallout to the fall 1918 pandemic? It is actually difficult to overstate the fallout because it spread in so many directions. I'm going to be talking particularly about Philadelphia today because that's the city I studied. I studied Philadelphia because it had the second highest death rate in the country, mortality rate, excuse me. Pittsburgh was slightly higher, but Philadelphia is a much larger city. So I was able to do work at the neighborhood level through mapping and some other tools to really see what the impact was. And so I chose Philadelphia over Pittsburgh. During the fall 1918 wave, which was the worst wave, we're used to thinking about waves now, right? The Delta wave, the Omicron wave, and we're used to watching COVID kind of go through the population. And that's really what happened with the fall 1918 outbreak as well. It really kicked up in fall of 1918. It continued infecting people through March 1919, and then it came back in the 19 to 20 winter. And there are some scholars who say there's good evidence that the 1922 wave would be a derivation of the 1918 wave. We only have DNA on the 1918 wave, so we can't be sure about that, but there are lots of reasons to think they're at least connected. During that fall 1918 wave, the miscarriage rate in Philadelphia was astounding. It was 60% at some hospitals. And infant loss, particularly in the first days with newborns, with mothers who were infected, was also really high because this particular influenza came with a really high fever. Patients regularly got to 104, 105, and then stay there for days, even with all the tools doctors were using at the time. Another big issue was how many orphans there were. In a 6-week period in the fall of 1918, just in the state of Pennsylvania, 40,000 children became orphaned. Now, what does that mean at the time? Orphans at the time were considered someone whose biological father had died. They did not need to lose both parents. You could be counted as an orphan if your mother died, but legally you were an orphan when your father died. And that was because the assumption was women would not be earning a wage that would allow them to support a family because they were paid about 50% of what men were paid for factory work and even skilled labor at like an electrical factory. And so the assumption was you got the legal designation of orphan if you lost your father so that your surviving mother could access charity because there really was no social safety net at the time. But what this meant is that the city had a crisis pretty quickly because they had families where the mothers were still very sick or they had young nursing babies. The hospitals and emergency hospitals were overwhelmed with mothers and babies that they were trying to keep together. And then there was nowhere else for the other children to go. So they made short-term childcare facilities in all of these different areas. And there's pictures in the newspaper of volunteers taking care of these children, 20, 30, 40 at a location until their surviving parents were well enough to bring them home. So orphans also presented a medical challenge at first because they needed to be separated from the sick and the convalescent so they could be taken care of. And they needed to be fed, clothed, and be, supported developmentally. And that was a real challenge, particularly in the first weeks following the pandemic. Something else that became a problem was children caring for parents. But I want to show you a quote from Dr. Harriet Hartley first. I just checked my notes. One of the things that historians talk about a lot in this pandemic is that it had a W curve, meaning that people between 20 and 40 were most likely to die. And that's true. They were. That's true everywhere. Over and over again, we see those numbers. But a lot of times people were remarking on how young people were not as likely to die and babies weren't getting hit as hard. Dr. Harriet Hartley, who ran the Division of Child Hygiene at the Philadelphia Bureau of Health, is trying to dispel this right away in the report they put out in the city. She says, in the first 2 weeks of the epidemic, it was thought the babies and little folks were escaping. But a study of the statistics showed that 1,813 deaths were in children under 5 years of life, and 1,117 of these babies in the first year of life. And she was reporting from statistics where they thought that around 13,000 people died in the city in those weeks. And actually, now we know it was more like 17,000 over the 3-month period there. Going back and looking at the records, a museum in Philadelphia called the Maternal Museum did a 3-year project on that and shared their data with me. So we know that it was more babies than we thought. And part of the reason for that is because children were left caring for babies and parents, because your 8 to 15-year-olds were actually less likely to get this strain, but their parents were so ill, they couldn't move or feed themselves or get out of bed. And so children caring for their parents put the whole family in a kind of nutritional peril, because 8 and 10-year-olds, even with the skill sets they had at the time, couldn't adequately cook for and feed not only their sick parents, but however many siblings they have. One example of this is Esther Davalos. She nursed her mother who got sick in October. Her mother was not able to get out of bed until November 11th, 1918. And Esther remembers this day because this is Armistice Day. This is when the armistice is signed, ending World War I. Hundreds of thousands of people pour into the streets to celebrate, and her mother gets out of bed for the first time to go to the window to see the celebrations. And then she said it took 3 more months for her mother to be able to get out of bed. And in the interim, she was trying to keep herself and her mother fed, and her teachers at school noticed that she was looking a little hungry and maybe not getting everything she needed. So they introduced Esther to the penny lunch program that was available in her neighborhood. And she brought a penny for lunch every day and got a 3-course hot meal at the school through a local program. But part of the reason she was nutritionally kind of unstable at that time is because she was the main caregiver in her home for 4 months after her mother became infected. And of course, there's parents caring for sick kids too. Even though, this W death curve happens, kids still got sick, and some of them got really sick and really struggled to recover. There's a 5-year-old girl. I do actually know her name, but because of HIPAA, I can't share it. So I will just say that there was a woman who took in her niece after both of her niece's parents died in the same week. She also was very, very ill at the time. She got influenza when she was 4 years old. A year later, she wasn't accepted into kindergarten because she was still considered too weak, and the school said her condition was too delicate for her to begin school. But the aunt had to work full time, so she wasn't really sure what to do in terms of childcare, because there weren't really childcare places taking chronically ill children. And this is something that COVID parents had to deal with in 2021 as well. The fallout, just physical conditions, range widely. And I am just going to cite what they said at the time. So I don't know if now we would say that influenza causes tuberculosis, but at the time, doctors were saying latent cases of tuberculosis were being woken up. People were getting kidney disease, ear and eye abscesses. People were losing teeth from drainage. People had heart trouble and lung trouble. A man wrote an op-ed in January 1919, and he said that hundreds of people with weak hearts were dragging themselves up the stairs to go to work. And he was worried that people might pass out on their way to work. And this is 4 months after the pandemic. So it took a long time for a lot of people to get better. And parents were caring for sick kids were caring for their parents. What happened during the COVID-19 pandemic? We probably feel like we know. We certainly know our experience, the experience of people around us and our community. It's been interesting to me, though, to look back at the numbers. We also have kids that were orphaned by COVID. Here are some, I have the link to this that I will share at the end. I did also put in the chat a link to this Prezi, so you can access it again and you can look at this information. This is data pulled from April 1st, 2020 through June 30th. And you can see here, if you count children that lost a primary or secondary caregiver in America, you have, getting up toward 400,000 kids. It's not actually a small number if we think about some of the reports we've gotten on some of the school lags, right? We know that having kids home and having kids out of school kind of put kids at a disadvantage because we couldn't just make it the same. But there's also kids who are struggling because they've lost a primary caregiver, and that has a direct impact on kids' ability to engage in school. We also know that there are racial disparities. This isn't new or different from any other pandemic. There were certainly disparities, particularly by class and ethnicity during influenza, and in some cases between the white community and Black folks. Although in Philadelphia, Black folks had a lower mortality rate during the 1918 pandemic. But here you can see that Indigenous folks have far and away just a higher proportion of people losing caregivers. And then this is a map of the spatial distribution. Now, I know the public health people in the room, there's lots of ways you can look at this, right? Part of the reason we see some of these really dark colors is because that's where the most people live, right? But in some areas, you also have this overlap because of vaccination uptake rates, hospital crowding rates. There's lots going on here, but it just gives you an idea of where folks lost caregivers. So we do have orphans, not at the same scale, but these are kids that we need to think about, and we need to also be thinking about their caregivers and the aftermath and how caregivers are able to take care of these kids with a particular kind of grief that they carry. And of course, we have long COVID and adults. We can talk about how we don't really have a definition for this, why we don't have biomarkers for it yet, how it's developing in the research, how patients led a grassroots effort with doctors from places like Yale and Mount Sinai in New York. We can talk about how we got to some of these numbers if that's of interest to people after. But in adults, we have millions of people that are newly disabled by COVID or who are struggling to get well, just like influenza. And if I'm thinking about people that have babies and toddlers who are not struggling to get well, I'm thinking about how these folks are trying to care for their kids in a really difficult time, especially because we know long COVID can come with brain fog, crushing fatigue, insomnia, and GI issues, and many, many more elements, depending on the individual experience. What really struck me recently is that the JAMA Pediatrics statement on long COVID in children. These are two of the places I found this number, but I keep hearing the number 6 million American children are potentially affected by long COVID. And that includes the whole scale, like really severe cases and not as severe cases. But the folks writing in JAMA Pediatrics pointed out that this is now the #1 chronic illness among children in America, and it's higher than the number of children that have asthma. I am repeating what I have read here, though that could change, but I think it is helpful for us to be thinking about if we work with children, if we're teachers, if we have children, that this is something that is now kind of rising to the top in terms of concern for what patients need and what we need to be looking for. And I think, as we know, kids maybe need different supports than adults do, particularly when we're thinking about development, social interaction, schooling, and the other things that as kids work. This is what kids are doing and what they need to be accessing. And if they are at home in bed, that becomes really difficult. So what kind of supports can we offer to these kids? So these are our medical challenges, and they are many. So how does that show up economically and politically? In the next section, I'm going to be talking about people that faced economic challenges and did recover, and folks that faced economic challenges and struggled to recover. In both cases, it was very difficult. The main reason it was difficult in 1918, again, is because you had your breadwinners dying. And this is your men between 20 and 40, and orphans were classed as orphans. You can see the Girard College admission papers here. This is the admission document that proved that the applicant was an orphan. They had to include the death certificate of the father to get on the waiting list at Girard College. This was a free boarding school, started in the 19th century, and they only took boys. And in 1918, they only took white boys. And that was overturned in the 1960s. Girard College still takes students today. They took 300 influenza orphans, just boys, just in the 7 years after 1918. And there was a 2-year waiting list the entire time. Both of the women, I'm going to tell you their stories, they were on the waiting list for Girard. And this is how their economic system kind of unfolded. The first woman lost a really good job, one of the most high-paying jobs in the city at the time for a woman. She worked at an electrical factory. She really struggled to get well after influenza. She had ongoing lung problems, and she kept getting double pneumonia every winter after her initial infection. The last time she got double pneumonia in 1920, she got fired because she couldn't keep up at work. So not only has she lost her partner and not remarried, so there's no main income coming in, and then she loses her job. And of course, there's no unemployment, there's no SNAP, there's any of the programs you can think of, none of those exist. So what she has to do is move home with her family and try to recover. And she had to institutionalize all of her children because she couldn't stay housed and she couldn't take care of them. And then there's another mother. She sticks out to me because she left a letter in the archives, and you don't often see that. They don't often survive. And the letter that she wrote was a little spicy, and it was really helpful to see how her frustration was communicated. She lost her husband, and then she could no longer afford rent. So she got another job. The only job she could get was across the city. So what she did, what a lot of people did in this time, she had her neighbor take on the care of her son. And then she went and worked at this factory. And the social worker came looking for this woman to interview her so that her son could finish the application process. But she went to the wrong neighborhood because she didn't get this mother's letter. And the mother said, "I'm really up against it. If you want to find me, this is where my new job is. You'll need to read your letters, but I'm out here doing my best." And she lived in a boarding house, and she eventually got her son into Girard. But again, this is another family that ultimately can't stay together because of economic pressures. You probably are all familiar with the fact that there were economic pressures during COVID as well. 88% of the people who lost jobs during COVID were women. In terms of the numbers of employed, the type of employment, the type of pay, there was like probably a decade and a half of reversal of progress, and that really hasn't recovered. Part of the reason those numbers stayed not great overall is because kids had to be out of school. And we were in lockdown. There are many people that didn't have kids that also had to do other kinds of caregiving for maybe elderly parents, relatives. And this put a lot of downward pressure on people's ability to keep their jobs. And because of how our society is structured, because we've had a shrinking social safety net, that just mostly fell to women. Do y'all remember the woman who was fired because her child was visible in a Zoom call? Yeah, her child could be seen. Now remember, all schools, all daycares are closed at this point. This is like March, April 2020. There was big pushback to this, but the idea that someone could get fired in a global pandemic because their child was visible, not heard, I think really clearly communicates what the work environment can be like for working parents and for mothers in this time particularly. And then now, when we have people that are struggling with long COVID or have kids with long COVID or are trying to support family members who might still be having trouble recovering or have just recovered, we have 300,000 federal workers getting fired, and many of them are Black women. So we really see again that when we are contracting the social safety net and public health systems, it's still really hitting families hard and women and Black women really hard. I think we've also all experienced the reversal of flexibility from maybe our universities or our institutions that we work for, where no, we're not doing hybrid work anymore. No, you can't work at home 2 or 3 days a week. And this also puts downward pressure on families who are struggling to feel better, who still have these medical issues related to COVID. I think another thing for us to think about in terms of economic pressure is the rise of disability in our workforce. In August 2022, when we were sort of first starting to talk about and define what long COVID might be, the estimates were around 4 million Americans. In December of 2024, I believe this is the Yale School for Public Health. This is part of an Instagram post they did recently. They talked about this study at the University of Pennsylvania. And these researchers found that 1 in 10 long COVID patients had 5 or more symptoms, and their count in America was 20 million people in total. And I do think that that is worth thinking about, whatever field we are in, because it means that it is likely that you either know someone or you know someone who knows someone who is dealing with long COVID. And the estimated economic costs of folks having long COVID and participating differently in the economy is $2.6 trillion. So not a small amount of money. And I will get back to what they're saying here about SNAP. Okay, so we have women are getting better or not, their kids are getting better or not, but either way, economically, it's a real tough time because we don't have a social safety net. So what grows out of this politically? This is a picture of the emergency aid aides. They're working with a mother here to apply for a mother's pension. This is kind of a new thing in the 1910s. It's well established by 1918. But Pennsylvania put together pensions where they agreed to pay mothers kind of a UBI, like a universal basic income, each week to help keep them housed and maintain family unity. Unfortunately, in Philadelphia and in Pennsylvania at large, they were not really interested in funding mothers' pensions. The first year, the activists, the women here who were also part of the suffrage movement, were progressive era activists working for public health issues and issues impacting women and children. They asked for $2.5 million in 1918 dollars, like $40 million today, to adequately fund this. And they got about 25% of what they asked for. In 1922, in Pennsylvania, but in Philadelphia, that made up the bulk of this list, there were 700 families who were struggling because of influenza that were still waiting to get anything, right? This is 4 years later. What people did get was really insufficient. A lot of the times it was $14 a week or $225 in today's money for like a family of 5 to survive. So it was never enough. And as a result, like we've talked about, thousands of families broke up and people had to put their children in spots around the city in different institutions. And most of them worked one or two jobs to help support their children in those locations. Presently, I would say it's tough. It's tough in public health. It's tough if you're an epidemiologist and you're watching what we're talking about in terms of preventing the spread of viruses. It's tough if you're a kid who needs services. It's tough if you had a federal government job. But I'd also like to point to these two pictures over here, which shows that our social safety net has, of course, been shrinking for 30, 45 years now. And the number of Americans that need to rely on food stamps because pay has not kept track with the cost of living, that has been going up. It continues to go up, but it's been going up since 2007 or before. And the families who qualify for and receive cash benefits, that number is just titrating down. So you can also see how families economically and from a policy perspective will have a really hard time dealing with any potential medical fallout or even just the regular economic fallout of having jobs change, having to be at home with kids without paid sick days, and some of those things. It really is challenging how people parented during the pandemic, and it continues to create challenges for families today. I think about the SNAP pause for a month. I know a lot of us were really concerned about that. And, locally people really stepped up to help people, but it didn't fill the whole gap, right? Because we need sort of large scale and local and state programs to offer the kinds of support that people need. So, okay. Thanks, Bethany. This was kind of depressing. You said a lot of things that are kind of sad. But there are things that we can do about it. And there are ways forward. And I'm going to even draw in some of the things that we know are available from 1918. There is some political will to change family paid leave. I need to make sure okay. It was I didn't know this existed. The House Paid Family Leave Working Group pitched the More Paid Leave for More Americans Act and the I-Plan program. Those have not gone through yet, but we have some options on the table. Okay, but we can all acknowledge that we're in a kind of crisis of failure to fund programs, rollbacks, and sort of the destruction of the public health system. Okay, so what do we do about that? This is where we can get really serious about local and state level programs and interventions. This is where we can organize again locally and work with individual organizations and companies to alter their policies. I understand that with international and national corporations, that can be much harder, but there are places, including churches, where you can show modular programs where you have paid family leave or more flexible policies, and then those can be used to encourage larger organizations to do that. But what I want us to remember is that there is not a policy that can keep us from taking care of each other. And what does that look like? Well, here are some things that we can do. So in medical and public health spaces, a lot of people are doing something called responsive masking. And that is if you are not doing that to protect yourself, if a patient comes in with a mask on, you can take out a KN95 and pop it on as a way to build trust and intimacy in that moment, and to say, hey, I see you're doing a thing here. I'm going to reflect that back to help you feel more safe here. And that's how we're going to build our relationship together. I know there's a lot of discussion about whether masking is effective or not, but I found kind of a cool story in the archive, actually in W.E.B. Du Bois's papers at Fisk, which, what an experience. So cool. But he had this World War I book he never wrote. And he had all these materials for it. And in it was a Senate report that included this story about a Black field hospital. So all Black doctors, all Black soldiers on the front in France in 1918. Actually, probably late 1918, early 1919. And they did this thing that they talked about in the Senate because they couldn't believe how successful it was. This was the only field hospital that was actually able to stop the spread of the 1918 influenza in their field hospital. And they did it by having the patients, the doctors, and the nurses mask. And they wrote about this in the report and they were like, oh, wow, everybody was masked and they stopped it. This is bonkers. So I don't have statistics that I can share about that. And surely it's more complex. They were also outdoors in a tent. But they had it staked really closely to the ground and they were able to maintain a certain amount of heat. So it's just interesting to come across those stories. I think any of us that have students, patients, clients, we can do responsive masking. And we can also continue to think about air quality and airflow. I know some of these things we might be tired of hearing about, but as time goes on, we have new and better research suggesting when we can use these tools effectively. This study I have right here, the effect of room air cleaners on infection control. This happened at a number of different centers. This is something that should be replicated. When they started using air cleaners, they had the number of days that people were absent was reduced by 60%. That's a bonkers number. And it's also a bonkers number that says, okay, let's see if this is replicable, right? But I think that open windows and things like that, these are all things we can do to just signal to people that we know it's respiratory season and we know that people might have lingering health issues or want to be preventing things. And this is ways that we can show up. Practitioners can do what doctors back then did, which is to make sure they know how many times people had COVID, what are their booster situation. These are things we can be asking, particularly as we're starting to hone in on what long COVID looks like. Boosters can be helpful if you are around mothers, if you are around babies or children, if you take care of children or elderly folks, or you are in spaces where you might be together. And then practitioners can also now, I've heard about this locally, they can write support letters for children who have long COVID. That's been a really difficult thing because it's not covered by the ADA. So what kind of institutional change should we think about? This is sort of like public health 101, right? We need paid parental leave, paid family leave, paid sick leave. We need potentially federal policy for caregivers. We need the long COVID moonshot. We need to be researching these things. I realize that I'm saying this at a time when we are pulling all of things back, but it's still worth saying. We need to maintain flexible work policies with home and hybrid options whenever possible, not just because people get long COVID, but because people get sick, especially young children and the parents of young children and people that work with the parents of young children or young children, right? We need to remain flexible and understand that if we don't have paid parental leave, we need some of these flexible work options. But I want to tell a quick story about the most incredible federal childcare program in American history that happened during World War II. And I've told this story a number of times and people don't believe me, but it was real. Okay, so the federal government started thousands of childcare facilities at factories where they had women working, and they had before and after shift care. They had people there 24 hours. So if you had to work the overnight shift, they had sleeping rooms and they had night nurses there. The government also, wait for it, funded food for these locations. So the kids were fed hot meals while they were there. So mothers did not have to pack lunches. And they met like nutritional guidelines. All of it was done on site. Now, why don't we have those programs anymore? At the end of World War II, they wanted women to not be in the workplace, and they achieved that by closing that childcare centers because that is what made it possible for women to work. We've done it before. We can do it again. Um, we also need funding. Um, SNAP, Head Start, Meals on Wheels, maybe extending Meals on Wheels to long COVID families. In-home care, before and after school care. We need to expand telehealth. But another historical model we can use is bringing back visiting nurses. These folks played a huge role in helping families get better and get back on their feet after every epidemic disease, but particularly after influenza in places like Philadelphia. They were also the first point people that said, like, hey, I think you need to see a specialist. Hey, I see no one's been able to work in 3 weeks. Let me get you some rent assistance. Let me get you some coal. Let me get you milk assistance. These were early social workers. There were social workers at the time, but visiting nurses were trained very similarly at the time, and it was a really effective program. Locally, we have organizations like Long COVID Families who are working with folks that still struggle with this medically, whether it's them or their kids. This organization was featured in Time magazine, but it's a Charlotte organization. It's a great one to check out. They have a lot of free tools and information. One of the things they say is, let's have accommodations anyway. I'm just going to finish us here. Unfit Parent is a really helpful book. I really love it. If you are somebody who does any kind of caregiving and it feels stressful in our social system, which is not made for caregivers or caregiving, which are the arguments of the other two books that you have here, Jessica Slice is someone who has POTS, which is something that a lot of people who struggle to heal after COVID end up with a POTS diagnosis. She had it beforehand. And she has 2 young children, and she has to be reclined about 80% of the time. And she talks about how they live their family life and how they create spaces and experiences that are tailored to their family's needs and how they do that successfully. It's a really beautiful book, super accessible. Meetings like this, where we get together and talk about these issues, publications like the Sick Times, this is the online publication that tracks COVID research, supports folks with long COVID, and it is a great source for that. Recently in the Sick Times was a beautiful essay by someone named Philip Hoover, and he said, I ask people to ask about my illness, he has long COVID, like they would ask about my kids. Kids are always changing and growing, needing to be parented in new ways. Illness is the same. In his essay, he encourages people to ask new questions and take seriously when people are struggling, understanding that things have changed and they might not be getting better the way that they wanted to. A recent study in the UK said that 63% of people with long COVID reported facing discrimination from friends, family, and coworkers after disclosing their illness, unquote. Hoover said, at the very moment people's lives fall apart when they most need support, the world steps back. I think that's in part because we're all very tired from this pandemic still. We carry the scars of that. But I think there are ways that we are learning in this time that we can support one another and we can depend on one another in ways maybe that we haven't before, that we can change how we support each other. And that builds the framework within which we can fight for this structural change. Consistent support, like getting groceries for somebody or shifting expectations and options for people that have young families, people that have young children, and or people that have chronic illness and a pandemic aftermath. You can eat outside, meet at a park, do a play date in your friend's backyard. Be willing to show up in ways that these folks need and that will build the ties together better. As we are learning how to support people in these different environments, we can take this knowledge into our fields, our families, our friendships, and we can do things in a new way. For example, supporting kids with long COVID. Long COVID is not a condition covered under the ADA or 504s or IEPs, but when kids push through, they can head to pretty dangerous collapse where they have crushing fatigue, GI issues, insomnia, joint pain, and other things. So, what if you're a teacher and you're just not getting support for kids where you're hearing from the family that they have long COVID? You might encourage them to apply for a space in the CMS digital school program. There might be other ways you can work with a school counselor, PT or OT services to offer rest times during the day for a student, or find other ways to support the family. And again, drawing on local resources is really helpful. There are things we can be doing for each other and that professionals are doing all the time for their patients. And we can absolutely be a part of that, because viral illnesses do really can take a toll, and they can take a toll on healthy families and healthy communities, even when we don't expect them to. Here are some selected resources. Again, I have the Prezi in the chat, so you can go look at all of this. So thank you. I went a little over, and I would happily take a few questions now from the chat.
Perfect. Thank you, Bethany. I'm going to stop the recording. Thank you.